It's a terrible thing.
Mansi, you can open the room now.
Good evening to all of you.
Good evening, sir. Good evening.
Good evening, sir.
Good evening. Be most welcome.
Good evening, sir. Good evening, sir.
Good evening, Raja. Good evening. Murthy, you're not on the screen. Press
I am
the,
there, sir. I am there, sir.
He's very much there,
the
sir.
video button.
I am there, sir.
Where? I can't see you.
Yeah, now he's there.
Upper panel, second picture, sir.
Sorry,
Upper panel, second picture, sir.
not on my phone.
Yeah, the phone will have little problem of not
Okay.
seeing all the videos.
Okay, okay.
Yeah.
Fair enough. Fair enough.
Sometimes, it allows only 4 or something. So you may not see everyone.
Okay, fair enough. Fair enough.
Yeah.
Learning. Still learning.
Uh, So in another 2 minutes, I think
Sure,
we will
sure.
start.
Shekhar, what we see here is the number of participants who are actually watching it, right? We can see a number of 48.
No, we are live on YouTube and we are live on Facebook also.
Oh, okay.
So the people will join at different places.
Right.
True.
Yeah.
So these are the ones only on Zoom.
Zoom, yeah.
Yeah, Zoom.
Sir, how are the rains in Chennai?
On and off, quite heavy sometimes,
Okay.
causing flood. Yeah. They're cleaning it up, but the heavy rain is still to come. The northeast monsoons have not hit us yet.
Okay.
In the bay, there is a depression, big depression.
Yeah.
Bay of, it's lightning, thunder since yesterday
Yeah.
going on.
Okay. But this time around, we had, I think, good rains.
Everywhere,
Yeah.
all over
everywhere.
India,
All over country, I
Every-
think we had good rains.
out of season, in season,
Yeah.
rains all over this.
It's rather more in Delhi, sir, this time.
Delhi had a bad time.
Yeah.
Delhi
Yeah.
had a really bad.
Usually it is a Bombay, but this time Delhi had a bad time for 2-3 days.
Pretty bad.
Bombay is accept. They all accept this is going to happen. Delhi was surprised.
Yeah.
Yeah.
Delhi was surprised.
Last 3 days, Calcutta is also having a torrential rain.
Calcutta?
Yes, sir. Yes, sir.
Vishwas, good evening.
Good evening, sir.
Okay. Dr. Bhave, where are you?
I'm here, sir. I'm waving my hand.
No,
I don't know if
Which-
you can. Oh, I'm
which-
okay. I'm in Nagpur.
no.
I'm a psychiatrist, and I'm here by virtue of Dr. Meshram's grace.
Part of my family lives in Nagpur.
Okay.
Yeah.
Uh-huh.
My sister's family, she passed away. Her son is a doctor there in Nagpur.
Okay. What's the surname, sir?
Her name is, her name was Pari, but I can't often get the name. I'll get it.
I mean, the surname of the family.
That's what you are discussing today, right? Yeah.
Okay,
He
I
was-
think, Sudhir, we
Yes.
can start.
Okay, we will. Yeah. Thank you, Shekhar. A very good evening to all of you. Namaste. I think we have all gathered here today on the occasion of the World Alzheimer's Day. 21st September every year is celebrated as the World Alzheimer's Day all over the world. I think all of you who have joined here know something about Alzheimer's. If not much, I think you have some idea about what the illness is all about. And I think it's a great pleasure that all the audience today wants to know more about Alzheimer's and dementia, because that is the very purpose of today's function. This World Alzheimer's Day is being celebrated under the auspices of Indian Academy of Neurology. Indian Academy of Neurology is a body of neurologists, doctors who deal with the brain in the country. And for the past many years, they have been doing a great job with disseminating knowledge on different aspects of brain, different aspects of various diseases of the brain, and so on. Now, I would like to turn to Dr. Chandrasekhar Meshram. Dr. Chandrasekhar Meshram has been a past president of the Indian Academy of Neurology. And I think the entire country's neurologists know Dr. Chandrasekhar Meshram's very significant role in creating awareness on brain diseases all over the country. He has headed several bodies which deal with creating awareness of various medical problems, has been heading again many important world bodies in neurology, like the Tropical Neurology Group of the World Federation of Neurologists. And there are many more accolades to his credit. So may I invite Dr. Chandrasekhar Meshram for his inaugural address. Dr. Meshram, please.
Thank you, Dr. Sudhir. On behalf of Indian Academy of Neurology, I welcome you all for this public education session on the occasion of World Alzheimer's Day. In fact, this is a whole month is celebrated as Alzheimer's month. And I extend my best wishes for the World Alzheimer's Day. Now, Alzheimer, this is the most important health crisis of 21st century, because it is a disease of civilization and industrialization. There is lack of information about brain health and brain diseases, not only in India, but all over the world. And 70% of the burden of brain disease and disorders fall in low and middle income countries. So neurological disorders are also second leading cause of death globally. Therefore, the public education about neurological disorders is very important. And the main idea is to create awareness about brain health and its disorders. So as we improve their health and decrease the incidence of disease and focus more on prevention so that the patient care and outcome is improved. Now we have, by Indian Academy of Neurology, we have been carrying out this campaign very extensively this year. And in our campaign, especially the print media has been very supportive, and I would like to thank them. For this today's important session, to inaugurate this event, we have Professor G. Arjun Das, who is the most respected and senior most neurologist in the country. He is Professor Emeritus at Dr. MGR Medical University, Chennai, and visiting professor as neurology at Madras Medical College. And he's also trained in Madras Medical College and then at Queen's Square, London, Neurology National Institute, National Hospital, and then in New York. And he's a founder fellow of Indian Academy of Neurology. He has been there from the day one. He's founder president of Indian Stroke Association, and he's visiting professor for various universities, national and international. He has been the president of Neurological Society of India and founder president of Indian Epilepsy Society. So you can see that, even at this age, he regularly organizes neurology update every year in Chennai for so many years. He has various research interests. He has published many papers. And this month, he celebrated his 22nd birthday. And on behalf of all, I wish him a very healthy and prosperous life. And I welcome you, sir. We also have President of Indian Academy of Neurology, Professor J.M.K. Murthy, who is Clinical Director and Chair, Department of Neurology, Care Institute of Neurosciences, Care Hospitals, Hyderabad. And he's a great academician. To moderate the session, we have Professor Atanu Bishwas, who is Professor, Department of Neurology, Bangalore Institute of Neurosciences and Institute of Postgraduate Medical Education and Research, and SSKM Hospital, Kolkata. Now, Dr. Atanu is presently the convener of Cognitive Neurology subsection of Indian Academy of Neurology. We also have soon to join Dr. Meenakshi Sundaram, who is Secretary of Indian Academy of Neurology. And we have extremely distinguished faculty across the country who are expert in dementia to highlight and enlighten you about Alzheimer's disease and dementia. We have Dr. Suman Kushwaha, who is Professor and Head, Institute of Human Behavior and Allied Sciences, New Delhi. And Dr. Suvarna Aladi, who is Professor of Neurology, National Institute of Mental Health and Neurosciences, Bangalore. Dr. Joy Desai, who is Consultant Neurologist at Jaslok Hospital, Mumbai. Dr. Sudhir Bhave, who is very close friend and a senior consultant psychiatrist in Nagpur and has been involved in public education activities for last 35 years. And Ms. Shali Abraham, who is Project Director of Alzheimer's and Related Disorders Society of India, Kerala chapter. So I welcome you all on this session, and I'm very sure that you will enjoy this session. And now I request our the youngest at heart, Professor Arjun Das, to inaugurate this session. Thank you, Professor.
Thank you, Chandrasekhar. Let me declare my age. I am 92. Just celebrated 1 week ago. So I'm very much interested in this subject, apart from the academics. I welcome all people who have joined us. I remember as a youngster being taken to a mental hospital in Hyderabad, Sindh, in now Pakistan. And the doctor took me around and showed me the various mental disorders. But there were some very elderly people there. They lived long in those days, and I thought they were not mentally disturbed. They were aged people, and they had dementia. So I'm so happy that dementia has been gradually separated from the confirmed psychiatric disorder. As I said, it is always said that if you live long enough, you will die of cancer. Some cancer rather. If you live long enough, the dementia is going to come. It's only when dementia comes before its time that you can help people. So it becomes very important today to define dementia. Sometimes in the rush of time, consultations, we don't spot it. Actually, the family spots it. If a person comes himself, say, I got this problem, that problem, the family comes for him. They record, they know, because they are lived with him. they can observe these subtle changes. So I think dementia is something that should be diagnosed early, like any disease. Any disease should be diagnosed early. Sometimes it's a pity that the diagnosis is postponed for some reason or other. Now we have learned that dementias can not necessarily be degenerative. There is a cause. Like imagine, we are neurologists. We have a stroke. We recover, hand recover, leg recover. Can you imagine that neuron that went through all the process? He will not have a normal life. He finished life earlier than the normal neurons. So you should look at it like that. The Alzheimer's disease is the premature aging of the brain. If it affects sensitive areas like memory, everybody notices it. He himself will notice it. The problem is when it is not so sensitive to be seen. So a lot of work is being done all over the world. I think you can say, what's the point? We don't have a tablet to diagnose early. So what are we going to do? I have a simple rule for them. These are elderly people who belong to the past. I might even tell you now that if you connect them even with their past, you can improve them. You can get them better, slow down the process. So it's necessary that we begin to, just like hemiplegia, begin to diagnose dementia in early times, which means a long interview, not with the patient alone, but his family. Of course, age group counts. Now with the modern technology, now they found you can find a neurofilament in the blood. It's a marker. It used to be CSF a few years ago. If you found the filament floating content in the CSF, then you know his cells are dying. But then there could be any other cause. So early diagnosis is becoming more probable, more possible. Now you say, what are you going to do with them? There are so many drugs come out now which can help them. The problem is the secondary dementia, like Parkinson's disease, other neurodegenerative disease. They also develop dementia. They are not primary dementia. If you're talking about Alzheimer's disease, we should talk about dementia. Then Alzheimer's is a primary disease. That's called a dementia. Rest of the dementia can occur any of these diseases. So Alzheimer's disease, I have not seen many cases. I'm surprised. I thought there must be many more cases who want help. There are not many cases, but I'm sure all of you must have seen many cases. And funnily enough, they're all from the city mostly. That's probably because the village people have no access for these kind of diseases. They'll come running to you if they have a chest pain. They don't use the hand or leg. But this kind of subtle things, they don't really bother. So I'm so happy that you're discussing a subject which is so subtle. At least to begin with, is very subtle. Based on that, so many drugs are being tried now. But more than that, the interpersonal communication helps these people to go on. For instance, an 80-year-old man, you make him sit in front of TV, put the film songs of 1980 or 1920. They are so interested in that. They can revive memories, recall those things. And it helps to lay a new track, a track that is not working. All these help. All these help. Simple people are not educated. Take a slate, write down the sums, minus, multiplication, division. One set in the morning, one set in the evening. They've been business people. They've been doing this for such a long time. You got to retrace the pathways they are not working. But many things can be done. At least I try to, now with the computers, there's so much they can do. So it is very important that we discuss about one type of dementia, Alzheimer's disease, primary dementia. And I don't know how many Alzheimer's units are there in India. Somebody enlightened me, devoted to only Alzheimer's, like they have in Hawaii, the aging, what is it called? Aging. These are centers where all the aged people are repeatedly examined for causes. But now recently I heard there's a blood marker for Alzheimer. Not CSF necessarily, non-invasive, which is something that tells us the subtle cases can be caught in advance. And there are so many things we can do to slow down the process. So I wish the meeting all success. You got wonderful people who have been working all their life in neurology and learning about these difficult cases. So I am here to listen to you. Thank you, Mr.
Thank you, sir, for your wonderful inaugural address and being with us and inaugurating this important event. We have Professor J.M.K. Murthy, President of Indian Academy of Neurology. Sir, would you like to say a few words?
Nothing. Very good evening to all of you, and welcome to Professor Arjun Das. And I thank him on behalf of IAN for inaugurating this wonderful public education program on Alzheimer's disease. I welcome all the distinguished panelists. I'm sure the attendees will learn a lot about Alzheimer's disease and also how to care them. Caregivers also, I particularly told Dr. Chandrasekhar to involve caregivers, and so we have a person from Kerala. I'm sure she will enlighten us very much. Thank you. Over to Chandrasekhar.
Thank you, sir. Thank you so much. And now I think we move on with the panel discussion about dementia. And there is a Q&A box. So you can ask questions and we'll take up your questions. So to do further discussion and to run the panel discussion, may I now invite Dr. Athanu Vishwas to carry out the proceedings further. Dr. Athanu.
Good evening and namaskar to everyone. A warm welcome to this public awareness program organized by Indian Academy of Neurology. I am really privileged that I've been given a task to moderate this session. This evening, we are going to discuss a subject very close to my heart. My mother is a maternal uncle. During my professional career, I've been seeing these patients for a long time, and I've seen them, their sufferings, and I know the difficulties their family members are facing in day-to-day life in managing or caregiving their near and dear ones. Looking at their devotion, it gives me strength to work for them and to carry forward the work so that we can build a dementia-friendly society in our country. So before beginning the panel discussion, let me say you something that we are in the middle of an epidemic. That epidemic of dementia. this is probably just the beginning. We are going to experience a huge number of dementia patients in the coming days. In India, around 40 lakhs dementia sufferers are living in this country. But this is just a rough estimate, reminding you all that only 10% of dementia subjects in this country, they go to the doctors and they get a diagnosis. Remaining 90%, they are not getting proper diagnosis because of the ignorance and because of the lack of facility in our community. And because of rising population, we are going to have almost 200 crore population by the end of 2050. And during that time, almost 1 crore 25 lakh people of dementia will be living in this country. That is a rough estimate and projection at this point of time. So that's one can imagine how much the problem that this country will face to tackle this pandemic, this epidemic in the near future. And burden is not only the number, it is also the sufferings of this patient. Dementia patients usually live a number of years, maybe 10 years, 12 years time, but they live with a disability, with their disabilities. And this disability over times gradually worsens to make them dependent on their family members and caregivers. So that leads to a tremendous burden to the family, to the society. And the economic cost has never been studied in this country. The cost here for these dementia sufferers, the direct cost, the cost of treatment, the investigations, the doctor consultation, transportation, and the indirect cost of the family members being not allowed to go out, not allowed to do their job, to earn for them, and also the intangible cost of the sufferings of the family members. This has not been studied in this country, but you can imagine the huge cost involved in these patients' management and caring for these dementia sufferers. We are also passing through a difficult time of the mankind. The COVID-19 has affected the life of all persons in this world. It has also affected the life of the dementia sufferers and also those who are caring for them. They are finding it difficult to manage the patients at their home because they are not allowed to go out. So in this backdrop, we are going to have a panel discussion. And for this, we have a distinguished panelist. Let me introduce our panelists. So can I introduce them with small slide shows? We have Dr. Joy Desai, who is the consultant neurologist at the Jaslok Hospital and Research Center. He's also the teacher of D&D students. He's consultant in charge of Epilepsy Clinic, Jaslok Hospital, Mumbai, and chief coordinator of the Comprehensive Epilepsy Surgery Program. His areas of interest are neurodegenerative disorders and epilepsy. He has several publications and presentations at national and international meetings in India, USA, UK, and USA. Dr. Suman Kusawa, he is the professor and head of neurology at the Institute of Human Behavior and Allied Sciences, New Delhi. He is also interested in cognitive and behavioral neurology as well as movement disorder. He started comprehensive stroke unit and IV thrombolysis in our hospital. She also involved in the movement disorders study support group and received several awards. She had many projects in her hand. She has more than 92 publications in national and international levels. Dr. Sudhir Bhabe, he is the professor of psychiatry at NKP Salfi Institute of Medical Sciences, Nagpur. He has 33 years of teaching experience, winner of several awards, published 26 papers in index journals. He's the chairman of the IPS specialty section of the cyber psychology and is an acclaimed light music vocalist. Ms. Sally Elizabeth Chon, who is the project director of ARDSI, the Alzheimer's Related and Disorder Society of India, who is an NGO working for the patients of dementia of Trivandrum chapter. She got introduced to this particular institution through her father-in-law, late Dr. K.V. John. And she has been working on the study of impact of the stress and care of caregivers working among institutionalized Alzheimer's patients on their families. She is also the clinical and pastoral counselor. She has been a good athletics, was in athletics. She is an athletic champion in track and field. She has interest in cooking and also the scripted drama, and she is involved in counseling of various school students. And finally, Dr. Suvarna Aladi, she is the professor of neurology at National Institute of Mental Health and Neurosciences, Bangalore. She has special fascination for cognitive and behavioral neurology. She was trained at cognitive neurology at Cambridge and also cognitive epidemiology in Edinburgh. She started the first memory clinic in India at Hyderabad and provided comprehensive diagnosis and care for more than 2,000 persons with dementia, a research interest in Alzheimer's disease, and various other types of dementias. He also co-founded the NGO Alzheimer's Related and Disorder Society of India, Hyderabad Deccan chapter. And she is the principal investigator of several national and international collaborative projects. Her professional affiliations include the lower and middle income countries representative of Alzheimer's Association, Vascular is professional and research interest group, and this is the president of World Federation Neurology Research Group on aphasia and cognitive disorders. She will be joining shortly for this panel discussion. So let me begin with the panel discussion. I request all the panelists to take part in the discussion. First of all, I'll go to Dr. Desai. It is a very common complaint for many elderly persons that they forget the names of the friends and family members. They often seek medical advice. Please enlighten us. What is the relationship of the subjective memory complaint to that of the dementia? And when these complaints are to be taken seriously? This is a very common concern of all elderly individuals in this country.
Yeah.
Yes,
yes, I agree that there are often subjective perceptions of impaired memory as we grow older. So if one wants to understand this at a very simple biological level, then the thing to understand is that all our memories are actually network engrams in the brain. What actually happens when we experience our day-to-day living. Our experiences are stored in the human brain in a small region called the hippocampus. And when we sleep at night, our experiential data gets transferred from the hippocampus to the regional brain parts in our sleep. And our cells talk to each other by an electrical transfer of ions, and these form a network, and this becomes consolidated when we sleep. So as the best memory that a human being can actually have is in youth, because our sleep qualities are very good. And we have a lot of science which shows that the subjective impairment in memory that occurs as we grow older could be in some extent linked to poorer sleep quality of the human brain as we age. Now, if one wants to know how does one differentiate this from dementia? Well, what we do understand today is that to diagnose dementia, there must be an impairment from the pre-existing in at least 3 or more domains of cognitive functioning. And we as neurologists and psychiatrists have divided cognitive domains into categories. You have memory, you have personality and behavior, you have language, you have visuospatial skills, our ability to orient in space and time. You have praxis. Praxis is the ability to perform a sequential learned task without having to focus on its individual components, like handling a remote to switch on the TV, for example. And finally, there is executive functioning, which is the understanding of cause and effect, anticipation, and differences between different categories. A large part of it is our frontal parts of the brain. So for an individual to be diagnosed with dementia, there has to be a drop or a decline in functioning in at least 3 of these various domains, not just a memory problem. And this should affect their quality of life, both at home and at work. And if it is progressive, then a neurologist makes a diagnosis of dementia. So it's fairly clear that the dementia diagnosis is based on a holistic clinical analysis of the spectrum and umbrella of symptoms that bring a patient to the clinic, not just a simple disorder of memory. Sometimes there can be in an elderly person a progressive impairment in immediate memory, and if on testing the other cognitive domains are relatively spared, both at the bedside exam and say complex testing by a neuropsychologist, then it is called minimal cognitive impairment of the amnestic kind. And this can be a designation in some people. And there are complex nuances for memory to be robust. We need the pillars of regular lifestyle, like mores, like exercise, good sleep, a nutritious diet, and equanimity and the absence of stress. If you have those 3-4 pillars of lifestyle that are intact in an individual, then there is a lesser likelihood that we will perceive our memories to be poorer.
Okay, thank you very much, Dr. Desai, for highlighting the common problem, the common man, particularly the elderly persons they are having, that they are forgetting. They forget the name of their close ones. They forget where they have kept their articles. But these are not serious complaints, and they should not be worried about. Sometimes when they forget what they have taken, taken in their breakfast, or they forget their way around their houses, forget the routes, or they forget to pay their bills at times, or they have problem in financial transaction or decision making. Probably these are very serious complaints and one should not ignore. They should consult a doctor, particularly those who are experienced in patients of dementia, neurologist or psychiatrist or geriatrician, or even if you are not available, a physician. So now I will request Dr. Suman to explain. People have a misconception that Alzheimer's disease and what is Alzheimer's disease and what is dementia. So please explain, are they the both same or they are different things, or if they are same, then what is this?
Thank you everyone for inviting me for this wonderful patient awareness program. So as the theme of the Alzheimer's Day 2021 goes, no dementia, no Alzheimer's. The question which Dr. Atanu has asked me is very valid. So we need to understand what is dementia and what is Alzheimer's disease. So I will like to explain in a very simple language what is dementia. Dementia is basically a brain disorder or a brain disease, we can call, for the common public, in which you lose the ability to understand. It means whenever anything is said to you, you are not able to understand. You will be having a lot of memory problems. You are forgetting the things of day-to-day living. You're forgetting the common ways which you are using, you're forgetting to come back to the house from your familiar places. You're not able to do the simple things, like a lady is not able to make the food what she had been using making the food throughout the life. And one is not having an ability to judge any situation. And not to forget, very important is the behavior problems which the dementia patients have. The behavior problems are usually the problems by which the patients are brought to us, to the hospital. Most of the behavior problems, either the patient has become very depressed, not talking to anybody, or the patient has become suspicious. The patient usually is having suspicious regarding the family members, that he or she is going to kill me, or he or she is going to have my money. And usually these patients have a tendency to wander around here and there. And sometimes these patients do have hallucinations. So we have two sets of dysfunctions in dementia. That is, one is cognitive dysfunction and another is behavioral disorder, right? So whenever the cognitive dysfunction and the behavior disorders affects your activities of daily living, we call that the patient is having the symptoms of dementia. Now, I have explained you dementia. What is Alzheimer's disease? See, we can have all these symptoms in different types of dementias. We have number of dementias, which we will be discussing further. So Alzheimer's disease is the commonest form of dementia in which you will be having all these symptoms which I have enumerated. And it is very important. I would like to emphasize again and again the community people who have joined us, the caregivers who have joined us, to understand, to recognize the symptoms of dementia. Either they can have cognitive symptoms or they can have behavior symptoms, and report to the neurologist at the earliest, so that we can have a plan for them to make them understand how to take care of the patients of dementia and the treatment, whatever is available to us. So that is it. Dementia is an umbrella term, and in dementia we have multiple types of dementia, and Alzheimer's disease is the commonest type of dementia.
Thank you very much for nicely explaining what is dementia. And Alzheimer's disease is the commonest variety of dementia that is seen in the community, not only in the Western countries, but also in India. But in India is also having a significant burden of cardiovascular diseases and patients of stroke, as Professor Arjun Das was talking about, that those who are suffering from repeated stroke, or even after a single stroke, they often come with a complaint of memory problem or behavioral problem. So I will ask Dr. Desai that this is a very common symptom. That's my father suffered from 2 episodes of stroke and recovered, but now he's behaving differently. His behavior has changed and he started forgetting. He's not the same person as before. Is he suffering from dementia? We will call him as demented subject. So can you highlight what happens after a repeated stroke to our cognition and behavior, and when we call them dementia?
Right. Very good. So the question is very relevant, and we know that whenever there is a stroke, a small part of the brain tissue that is involved in the core of the stroke undergoes some degree of damage, which may not necessarily be reversible, which means that if somebody has numerous strokes, there is a possibility that over a period of time, bits of tissue, perhaps sometimes strategic in terms of the brain networks, may have been lost due to the damage produced by a stroke. Therefore, it is not too difficult to understand that if there is tissue damage in the brain, then the brain requires neural networks to function as an integrated whole. And therefore, when there is tissue damage, if it occurs in strategic parts of brain networks, which is important for cognition, say for memory, for behavior, for visuospatial skills, finding our way around in time and space, for the parietal regions of the brain important for praxis, for example, then those functions are likely to be impaired. And we now have a concept that says that a person who has repetitive strokes could be vulnerable to a condition that neurologists like to call vascular dementia. And vascular dementia can occur in a stepwise manner of gradual but stepwise deterioration in the perceived ability of that person to function with their abilities every time that they've had a stroke. Now, that's our classical understanding. But the muddy waters in this whole concept is that we also know from pathological studies in patients that many such individuals, when their brains are studied at death, they also have confounding pathological features of Alzheimer's disease besides these strokes. And there are studies which show that this occurs in about 40%. Now, the one way of looking at this is that many of the processes that can lead to an aging brain, resulting in either a stroke or in compromise of brain integrity because of the pathology of Alzheimer, can have common risk factors in terms of life and lifestyle. The risk factors can be diabetes, hypertension, sedentariness, poor quality of sleep, poor choices in diet, which are all contributing to these dual pathologies that can occur. So, if very simply, best way to understand is that an individual with repetitive strokes is more at risk of vascular cognitive impairment. If it is fairly large, it can result in dementia. In a small number, there may be also a degenerative process, and therefore they need the assessment of an expert like a neurologist who has an interest in dementia, or a psychiatrist who has experience in dealing with this, or a stroke specialist and a cognitive neurologist like Dr. Kushwaha. And you integrate all these things and come to an understanding of how can we best help this individual whose brain is at risk from progression with time, and the risk factors that make them susceptible to all these things that are happening, strokes as well as degeneration.
Thank you, Dr. Desai, for interesting comments on this. I think Subarna has joined. Welcome, Subarna, for this panel discussion. You are muted.
Thank you. Apologies for coming late.
No, it's fine.
Thank you.
Hi,
Hello.
everybody.
Hi.
Hi,
Joy.
Swarna.
So now I will go to Dr. Bhave. That all along we have been talking about the memory, and many of these elderly persons, they come with the memory complaints. Can dementia begin with the psychological symptoms like depression or any other abnormal thought process? Can you highlight that? Because elderly persons, they often come with behavioral problem and they are diagnosed as dementia. Please explain this.
Oh, that's very true. I think that's a very good question. It has been emphasized that dementia generally begins with a slowly progressive memory decline, especially for the recent events. Now, apart from the memory difficulties, there are quite a few patients with dementia who initially show psychological symptoms. The family might start seeing that the person has become unduly withdrawn, has started talking less, is not communicating with others, seems kind of indifferent to what's happening in the environment, which is quite uncharacteristic for that person. Now, this is often a part of dementia. And then there are patients who do present with symptoms of depression, like feeling very low, talking of very pessimistic things like hopelessness or death wish, life not worth living, losing their sleep, losing their appetite. In fact, sleep difficulties are, if you can call it psychological, sleep difficulties are a common early symptom of dementia in many patients. There are patients who present with anxiety. They would come to you with jitteriness and fidgetiness, and they're not able to sit quietly at a place. They might keep on pacing in the room. Now, these are the kind of patients who are generally initially thought to have a psychological problem, and they are often taken to a psychiatrist. And often the psychiatrist also may not be able to diagnose these cases as having dementia, because the characteristic features of dementia have not appeared at all by then. But it's only slowly over time that things evolve. The general rule is that if an elderly person without any earlier history of any psychiatric illness, without any significant family history of any psychiatric illness, if he or she starts presenting with psychological symptoms, depression, anxiety, sleep difficulties, behavioral changes, etc., at a relatively late age, like say late 60s, 70s, 80s, it should be suspected that the person probably has an oncoming dementia. Suspected, though it's not confirmatory. Now that's about Alzheimer's. And then there are types of dementias in which psychological symptoms are kind of at the forefront. Like there is something called frontotemporal dementia, in which this part of the brain, they are involved. And these always present initially with behavioral difficulties, lack of social judgment, being garrulous, being tactless, and saying things and doing things which are quite uncharacteristic for that person. And it's only slowly that in frontotemporal dementia, the diagnosis becomes more apparent later on, as these people become more forgetful and start losing what is known as their cognitive or intellectual abilities. Then there are some varieties like Lewy body dementia, in which the patient can start seeing things, visual hallucinations, which are not existent. So, yeah, I mean, there's a significant proportion of patients in whom dementia can start with psychological symptoms.
Thank you very much, sir. Now, many young individuals are seeing this program, but they are worried that they might get the disease once they become old. So what are the risk factors for developing dementia? What do you know about this? My question is to Dr. Suman. Please highlight the risk factors for development of dementia.
So, this is a very common question which we come across whenever a patient of dementia comes to us in our clinics and asks the son or the daughter usually as, will I be having dementia in future? So this is a very common thing which we come across in our clinics. So there are some risk factors for dementia, and which is basically divided into two types: a non-modifiable risk factors and the modifiable risk factors. So we need to understand these risk factors, as the non-modifiable risk factors would be the age. Aging is a universal phenomena, and we all will be aging, and we are aging. So aging is one of the things which we cannot modify, and the dementia or the Alzheimer's disease is a disease of an elderly age group. So we have to be very clear in our mind. Once we are aging, we can have dementia, right? And the second thing is the genetic constitution of an individual. So the genetic constitution of an individual is from my parents or from my forefathers. So there are some genetic risk factors, the ApoE enzymes, which is, if found in an individual, have an increased risk of having dementia. So these are the two non-modifiable risk factors which are there, as which make you having dementia in future. So you should be taking, we cannot actually do anything about these non-modifiable risk factors. But as far as the modifiable risk factors are concerned, it has been beautifully explained by Dr. Desai, the vascular risk factors which are coming into picture nowadays as a cause of a contributory factor in Alzheimer's disease or a type of dementia, that is vascular dementia. So these are the risk factors which we can control. We can control hypertension, diabetes, we can control hypercholesterolemia, we can control hyperhomocystinemia. So these are the preventable risk factors which, if we take care of, we can prevent dementia to some extent. Besides that, if you are having a healthy lifestyle, you are doing the physical activity of around 45 minutes thrice a week, and if you're having a good diet, like you are having a lot of vegetables and fruits in your diet, so there are chances that we can prevent dementia to some extent. So these are the risk factors which we need to understand, that if I am going to have a disciplined life in all these, understanding all these risk factors. And the important thing is that making your connections very prominent. Like if you are using your brain, if you are having one or the other activities, if you're acquiring any new activity in your lifestyle, in your lifespan, like if you're learning something new, a music piece, or learning to play a instrument, then these are some of the things which will activate your brain. The more you use your brain, there will be less chances of getting the dementia. So there are modifiable risk factors and non-modifiable risk factors, and we can always look for or vouch for the modifiable risk factors in our life to prevent the dementia.
So thank you very much for beautifully highlighting the risk factors and the type of prevention we can take. And Dr. Suvarna, please, can you join us? Because you have several works on this of preventing and the dementia in our country is a very tough job, but you have worked on multilingualism and also the other aspects of dementia prevention. Can you please highlight that?
Right. Thank you, Atanu. So I think all the panelists have actually mentioned that there is a window of opportunity to actually reduce the risk of dementia. People have reviewed all studies from across the world, and they have identified that nearly 40% of the risk of developing dementia actually can be modifiable. So I think the first thing is to know that you can actually reduce the risk of dementia. It's not somebody tells you if you do this, this will happen. It's not astrology. So you can be pretty sure that today if you do certain activities, the risk of dementia comes down. So of them, I think there are several factors, but if you specifically want youngsters to start some things that in their midlife or in young age, I think it would be physical exercise. It would be physical exercise, keeping the weight under control would be one of the activities that one should take up, any kind of exercise. The other thing would be to do complex skilled activities. So it could be playing a musical instrument, it could be learning a new language. The way all of these factors actually work is, to quote from Ramon Cajal, every man, if he so desires, can sculpt his brain. So we can actually sculpt our brains and increase connectivity so that they can withstand the effects of disease. It's not that the disease will not come, it will come late. And if you live long enough and if you work hard enough, you might actually delay it for much longer. Socially engaging activities. I think one thing the COVID pandemic has taught us is that regardless of whether this was a child who was not going to school or an older person with dementia, cognition declined. Cognition declined in most studies. It's a rapid decline. So social engagement is food for the brain, and there is evidence that it actually delays dementia. If you talk about public strategies, early life education, being able to read and write, it might just have healthcare benefits, but you might improve health access, but it's also the brain actually changes its structure when people are able to read and write. So taking up a complex hobby. So these are some of the positive things. Having a purpose of life. So there are studies where people have followed or middle-aged people for about 4 decades. And then after 4 decades, when they eventually died, they studied their brains and they found that people who had a purpose of life actually were able to withstand the effects of pathology. These are some of the positive behaviors. In addition, hypertension, diabetes, not smoking. Then if you have a hearing problem, to actually correct it. A lot of people, older people say, okay, I can't hear very well, it's all right. But the lack of stimulation actually is not good for the brain. So here, treating any kind of hearing impairment, depression. It's very important to treat depression because that is one of the risk factors. There are some risk factors that you should avoid and some health promoting factors. Diet, we still don't know in the Indian context what kind of diet protects. However, the Mediterranean diet, lots of vegetables, fruits, grains, low on dairy, can actually go a long way in protecting the brain. These are some of the things.
Sleep.
Thank you very much for beautifully highlighting the protective factors and what preventive measures young individual can take to prevent the development of dementia. At least we can slow down we can delay the onset for many activities. Now, diet has an impact.
I forgot one point. Stress is important. To deal with stress, building emotional resilience is also very important. That's the last point. Sorry.
Sleep hygiene.
Oh yeah, sleep. Yes, Joy. Yes.
Yes.
Thank you.
Thank you. So now diet also plays an important role. So Dr. Mesram is here. He has been working on this subject. I would like his opinion and to tell our audience what he thinks about the role of diet in preventing or in management of dementia. Dr. Mesram, please.
Yeah, thank you, Dr. Atanu. I think you are enjoying this session and the session is going on very well. So regarding the diet, as you know, the diet in diabetes is very important. And we talked less about diet in other diseases and neurological disorders. But now dementia is called as type 3 diabetes. Because brain is not, what happens in diabetes that the glucose metabolism is not proper. So in dementia, the brain is not metabolizing the glucose properly. So it is not getting enough energy. So there is chronically high insulin level in the blood and there is insulin resistance. So diet should be such that your blood sugar is normal and serum insulin levels are normal. Because brain can use glucose or fat or ketones for its energy. Now, to give a simple example that how glucose is as an energy for brain is bad and why fat is good is that it is like, if you have a car and or a truck and you put it kerosene into that contamination, so it will run, but it will be damaged soon. But if you have a car with a petrol or an electric car, it will run properly, it will cause less pollution, and its engine will not be damaged. Same is true with when you have a diet which is high in carbohydrates, diet who has got sugar content or sugar containing products, sweets. We are, not giving sweets only to India, but exporting the sweets all over the world and making the people sick. Junk food, packaged food, soft drinks, fruit juices. You should have moderate proteins in diet and a good fat. It is very important that which oil should be used for cooking. And one should avoid the vegetable oils like sunflower oil, soybean oil, rice bran oil, because they contain more of omega-6 fatty acids and which are highly inflammatory and damaging to not only the brain, but to the body and the heart also. So use saturated oil, and I think coconut oil is best. And when I say this, the Shally will have a smile on her face. Use ghee, butter. Egg yolk has an excellent quality fat. And why good fat is important? Because brain weighs only 2% of the body, but body's 25% of the cholesterol is in brain. So if you have a high carbohydrate diet and low fat diet, it is not good for brain. And you should have more of vegetables, green leafy vegetables, or different colors of vegetables in your diet. And when I would say that fish is also good for brain, Dr. Atanu will have a smile on his face. And there are studies that just by changing the diet, the symptoms of Alzheimer's disease or dementia can improve. And I must also mention that vegetable diet is deficient in vitamin B12. So those who are purely vegetarian or vegans, they should take supplement of vitamin B12. And in elderly, there is a problem with the absorption of B12. So you should have, if there are symptoms, then you should have injectable B12 as a supplement. Thank you. I think we can have more discussion on the diet. It's a very important topic.
Thank you, sir, very much for giving a comprehensive account about the diet and the prevention of dementia. Now, I would request Ms. Abraham to come in so that you please explain what are the problem a caregiver faces while dealing with the patients of dementia, looking after the patients of.
Okay, thank you, sir. Thank you for inviting me as a panel member to take part among all you all eminent personalities. I'm really grateful to that. Okay, now let me come back to the point. I'll talk from both the point, that is the patient point and the caregiving point. See, I would, has these 12 years experience and as a counselor, I would every time tell, we'll have to educate the primary caregiver plus the associate caregivers what Alzheimer's is, because the cases which comes to me and which I've dealt, they keep telling me, maybe it is a husband or their brother or their wife, whatever it is, they keep telling me that the person who's affected Alzheimer's is not really because his memory is off and on coming. So what they have an impression is that Alzheimer's is completely a memory loss problem where there is no memory at all. That is the greatest mistake and greatest wrong what the primary carer has. And because of this, the issue comes that, see, a Alzheimer's or a demented patient is a normal patient where the memory comes and goes off and on when the environment and when the circumstance is happy for them too. So the study and whatever I've seen is that every time the primary carer has a set pattern in their family while waking up in the morning. This should be done, this should be done. And this is imposed on an Alzheimer's patient also, where every time an Alzheimer's patient might not act the way the primary carer needs. I can give you an example for that. Using words, using terms also makes it a problem. For example, in a prayer section, that is a family prayer section, the lady of the house just prayed in between to the God that, oh God, please give us peace. This person of the family is giving a problem. See, she just told out of her frustration, but this person knew, the person who was affected knew that there is some issue. And the moment after the prayer, it was a night, the patient became quite frustrated, aggressive, and he just wanted the lady, his wife, to go out to the house. See, when I just spoke to them, what happened? Only her prayer word agitated him. See, that is one thing. And from the patient's point of view, never try to give them any bias type of conditions or anything. When a certain type of pattern is created in the family, there is no much problem for both the caregiver and the patient. This is from a study, what I say that the primary carer has to be educated what exactly an Alzheimer's or a dementia is. So I think 75% of the problem of the caregiver will be avoided of their own ability to cope up the thing.
Very important from caregiving point of view, because they are the sole responsible person to take after the patients, and if they get frustrated or they get depressed while doing the caregiving, it becomes difficult for the patient to be managed. So there needs to be taught how to tackle the difficult situation at their home, and for that reason, sometimes we are called for, doctors are also called for. I request Dr. Bhave to talk about the management of these psychological and behavioral symptoms in a patient of Alzheimer's from a doctor's perspective or a psychiatrist's perspective.
Right. Thank you, Atanu. If we think of the psychological symptoms of Alzheimer's, I think all the caregivers who have ever taken care of a patient with Alzheimer's or any dementia knows that there are sometimes less, sometimes very significant behavioral difficulties, which are perhaps at times more difficult to manage than the intellectual or memory decline. I think what Shaili spoke largely, I think very well gives us some idea about how to prevent these kind of problems. Now, if such a patient is brought to us, a psychiatrist, with behavioral problems, then we look at it from 2 points of view. One is psychological management, and second is giving some medications. Now, when it comes to psychological management, the psychological management of behavioral problems, it has got to be done through the family or through the caregiver. Caregivers are given an appropriate advice, like how to relate to the patient with dementia and how to behave so that their behavioral difficulties decrease. There are 3-4 principles involved here. One, the doctor and the family should try to look at, are there any physical or psychological stressors, any significant stresses in the patient's life. Like, for example, physical stresses could be in the form of some pain somewhere, some pain of which the patient could not complain, some fracture which went undiagnosed, which does happen in quite a few patients, or maybe a bladder which is full and the patient has not passed any urine, and that full bladder gives rise to a lot of agitation, aggression, irritability, and anxiety, and so on. So look at any physical stresses that the patient has, and look at the psychological stresses also. Like is our that is the caretaker's behavior contributing in some way to the patient's undesirable behavior? Like, are you getting rather too domineering or aggressive with the patient, prompting him to get even more aggressive? So removing psychological stressors is something which is very important, because unless you identify and remove stressors, I think any kind of treatment, any kind of medication is not going to help. Secondly, looking at the patient's environment in some detail. Like, is there something in the environment which is leading to difficulties? For example, an environment that is too noisy. Patients with dementia often are unable to tolerate a lot of noise, or lights which are either too bright or lights which are too dim, so that there are shadows that give rise to illusions, may trigger hallucinations, or might confuse the patient more. So looking at environment is very important, and environmentally we can help the patient in several ways. Like, for example, playing music which the patient loves. I think music therapy, use of music in treating patients with dementia, is something that is rather well established. So if you have any patient who is suffering from dementia at your home, and you know as to what that person's favorite music was, then I think playing that music reasonably frequently to keep that person in good humor is very important. Or maybe using pets to help the patient. So these are some environmental ways of handling behavioral difficulties. And the third important factor is scheduling the day in such a way that the patient with dementia remains fairly oriented through the day. The day gets a structure as to what is to be done at what time of the day. Maybe you can put in exercise in the morning. Exercise helps in dementia in more ways than one. Maybe you can have some pastime activities like, say, dancing. Dancing is known to help patients, especially in the early phases of dementia, or trying to involve the person in certain things that the person has been liking since earlier. For example, a patient with dementia who used to love cooking. So involving her in something connected to cooking, like maybe cutting vegetables to the best of her ability, or maybe helping in any possible way in cooking. So that is likely to keep the patient in better humor, decrease irritability, decrease aggression. I think controlling behavioral difficulties is, I might say, a lot of common sense. I think anybody who has a good empathy with the patient, can empathize with the patient's plight, can look at things from this intellectually deprived patient's point of view. I think the solutions might be easier to come. And the second thing I said was medication. Using medicines to calm the patient down, to decrease the behavioral problems, they are definitely not the first line option. But sometimes they might have to be used if psychological options are not working. And there are medicines that we as psychiatrists are often called upon to give. And these medicines are fairly safe in patients with dementia. And they do help in calming down the aggression, the anxiety, the agitation, the sleeping difficulty, etc. in these patients. So I think any good neurologist or any psychiatrist can definitely guide the patient in these regards. Thank you, Atanu.
Thank you very much, sir. Very well said. Because this is a common misconception that once a person with dementia gets agitated or become restless, or it is a common misperception even for the doctors to start a medication to calm down the patients. But it is not always true to give this drug to these individuals. It is the behavioral therapy or some modification in the home environment, or addressing the problem. What is the causation of that symptom is very important. Thank you very much, sir. Now, we have been passing through a very difficult time. The COVID-19 has affected all our life, and so also the life of the patients of dementia and their carers. Ms. Sally, can you please highlight what are the problems they have encountered and what happened to them in the life of
Yes,
the patients?
yeah. The main problem was that, see, the main problem what came through me was that the main primary carer might be the wife or the husband. The children part, they are all out of India and they couldn't travel down all these 1.5 years. And the stress got increased into the primary carer, thereby there are less chances for putting them into an institution, and there were very less chances to get the help from the external also. This created more problem on the stress part of the caregiver, and thereby that in turn it entered into the patients too. So what happened was that Alzheimer's is there on one side, but the behavioral changes of the patient went into a patient as well as a caregiver went into such a state that the primary caregivers had to go on psychiatry level, because their physical health, the mental health, the emotional health all got affected. One thing is that they can't go out because of this COVID. The second thing is that no help from out. The third main thing is that from their dear ones, there is no emotional plus physical help, where the primary carer is given a change of a gap in going through these patients. Thereby, what happened was that in general, when we take, fear factor has increased in all the life. That is, the primary caregiver wanted help from out but can't. So that went to fear due to the COVID. That again went to sad. That again went to helplessness, and that reached into depression. This is what is going on. And the main thing is that going to a doctor for a consultation has also become a big factor. Maybe in the cities it is okay, but on the suburb parts, they hardly go for a doctor consultation So whatever medicine was given, they continue it, which is not maybe which has to be changed or which has to be increased or maybe something else. This is going on and on. And now the thing is that in the end, helpless state, these patients are left to the institutions. But as what one of the eminent personality told, the lifespan, if it was a home care, could have increased, but because of the institutionalized, within a month, the patients are going away, taken away from the world, because the change of atmosphere, the change of their home maybe, or their circumstance, the main thing is change of home has given the patient plus the primary care, because the primary care is not allowed into the institution as it is as following the protocol of the COVID. So it is given a very big negative impact on the caring part and on the emotional part, plus on the lovable people where they also can't do anything. From faraway countries, they call and tell what to do. They have money, but money doesn't help everywhere.
Okay, thank you very much. Anyone wants to add anything to this? Because COVID-19 affected all of our lives, and many of our patients and their relatives are facing problems. So, Subarna, can you please?
I think Shelley has put it so well. We also had a similar experience, but the way you have explained to us, you have spoken, I think, to these people. I think your learning has come from speaking to one person after another person after another person. So what we did a research study. We called up people during the lockdown period. Then we called up people during the lifting of the lockdown. And again, recently we called them up after these vaccinations. So we looked at their, we spoke to them, and see, the thing about COVID was, this research was never done. Nobody knew. All over the world, people were having similar experiences. Like the vaccination was produced, like we learned that whether this ivermectin works or doesn't, to our horror, we discovered that people started deteriorating. Persons with dementia started deteriorating. And that was universal across. So we kind of quantified it using the kind of scales and all of that. And we found that we can publish it and all of that. But the experience has been universal. Cognition declined. Behavioral problems worsened. Caregiver stress increased. So what Shelley is saying, I can't really improve upon that. I think that was everybody's experience.
Thank you. Now, coming to the basic question, as at the beginning, Dr. Arjun Das and Dr. Vesram was also talking about that diagnosing dementia very early is important. Why it is important to diagnose them early? This is a very important question because many elderly or those who are young individuals, they will go search doctors for their memory complaint, but we do not know exactly how to handle them if we diagnose them as a dementia. So, what is the reason? What is the purpose of diagnosing early? Suvarna, can you please?
Right. So I think it's an important question. We've just released the World Alzheimer's Report. I was on that meeting, and from across the world, I think 1,000 people joined. And the theme this year is no dementia, no Alzheimer's. That means you must diagnose it. The whole theme is about early diagnosis. And I think, to put it very simply, first is, at least in our context, it could be a treatable cause of dementia. You can't assume that it is it's Alzheimer's disease. So you might pick up something that you might reverse. Second, if you listen to people when they go from, when they're living with a person with dementia and they don't know it's a disease, for years together, there is so much stress in the caregivers that if only they knew that this person was doing this because he had a disease, a lot of damage could be controlled. There are people who have lost lakhs of money. There are disinhibited people who have lost their jobs. There are people who have lost their way and never been found. So a lot of catastrophe and stress can be avoided. The third reason is there is very clear evidence that if you intervene, whether it is through medication or whether it is through cognitively stimulating therapy, engage the person, this progression of disease is slowed down. This is very good for, there is non-pharmacological treatment and it works. And people definitely get better for some time and then their progression is slow. And the final reason will be, if you pick it up very early, say it's a very educated person, they might want to know, they might want to plan their lives. They might have things that are undone, unfinished, which they might, and even an advanced directive, they might want to decide how they want to live with the disease. So I think for these 4 reasons, an early diagnosis is very, very important.
Okay, thank you. Sir. Now, talking about the treatable causes of dementia, yes, so we need to find out them because we should not jump to a conclusion that this disease is a degenerative disease. Anything to offer at the moment, only the caregiving. So, to diagnose and to manage the treatable causes of dementia, Dr. Suman, can you please highlight? Suman is there?
So we have always been told and we have always been taught that dementia is not curable but treatable. So here I would like to emphasize on some of the causes of treatable dementia, or we can say partially reversible dementia. So and even in the cases of dementia, the degenerative dementia, we always find the causes which we can reverse. Say, for example, in the patient of dementia, degenerative dementia, who comes to you, and the patient is on having multiple drugs. So there is one or the other drug which the patient is on and which is causing the deterioration in already cognitively challenged patients. So there are a possibility of lots of drugs which you have to check on when you are seeing a patient with cognitive deficits. See the drugs which the patient is on. Say, for example, the commonly given drug, anticholinergic drugs, which we give. These are the drugs which make the patient demented, or which have a impression on the cognition. So once you take out these medication from the patient's pharmacy, then you can see that there is an improvement in the patients of dementia. There is improvement in cognition. So the first and foremost, you need to check out the drug history of the patient. Is there any drug which is causing the cognitive deficit or deterioration in the cognition? So drug is a very important cause of reversible dementia. Now coming on to the vascular causes, which we have already discussed, Dr. Desai has already discussed a lot of factors which causes vascular cognitive impairment and vascular dementia. And if we treat these factors timely, like hypertension, diabetes, I'm again emphasizing these things because these are the common causes which can cause dementia and which are treatable, like hypertension, diabetes, hypercholesterolemia, hyperhomocystinemia. These are all treatable causes. So once you have any of these, then it is better that you go to your physician or the doctor and get the treatment for all these ailments and all these derangement in the metabolic symptoms and metabolic causes, and you can have improvement in cognition. Another cause, which is infection. India is having lot of infective causes of dementia, which the other part of world do not have. We have lot of infections, like we have herpes, we have tuberculosis, we have neurocysticercosis. So if we treat all these neuroinfections timely, HIV also. So if we treat all these infections timely, early, and give the adequate treatment, then we can have some part of reversibility in the cognitive functions due to infections also. Another very important cause is trauma. If one has trauma, multiple trauma, and the patient has landed up into subdural hematoma, and if the patient comes to the hospital and treated timely, the subdural hematoma is treated, surgically operated, and then the patient have a chance of improvement, rather complete improvement in the cases of subdural hematoma. Similarly, we have a lot of brain tumors which end up having a patient causing cognitive deficit. If these tumors are operated timely, then also we have reversibility of dementia. Another very important cause pertaining to our country, because most of our country people are vegetarian, is vitamin B12 deficiency, which is fully treatable. Like the patient with vitamin B12 deficiency, if treated timely, can have reversibility of all the cognitive impairment which they have. And lastly, the thing which we are seeing since last decade is autoimmune cause of dementia. They are easily treatable. So any of the young patient coming to you with cognitive deficits, you should always look for any autoimmune cause, because autoimmune causes are treatable. And lastly, not to forget, is your patient having depression and causing dementia, a pseudodementia? And if you treat depression, then the pseudodementia part is improved. So we have multiple causes of reversible, partially reversible dementias, which you should always look into whenever you are dealing with a patient of dementia. And in the patients of degenerative dementias also, it is always said that we have to rule out all the reversible causes of dementia in these patients. So this is the important cause of cognitive decline. We must all understand and look for into it.
Thank you, Dr. Suman. This is very important because once you have a relative who is having cognitive symptom, don't jump to a conclusion that he is having Alzheimer's disease or degenerative disease. Take advice from the doctors, get evaluated. Unless you know that the person is having a proper a particular type of dementia, it is not always true to jump to the conclusion that this is not curable. Now, Dr. Suvarna has already told that early diagnosis for degenerative dementia is also very important to manage them very effectively. And yes, of course, although we didn't have drug in the past, but now we are getting newer drugs which can be used for the early disease state, and the disease can be halted or can be prevented from developing in the full-blown course. Now, I will take up some of the questions that our audience has given in the chat box. Mr. Ajay Swatkar has given that, there is any age from where dementia starts? Is it fully curable if detected at the initial stage? Almost we have answered this, but is there any typical age where dementia starts? So we always talk about dementia as to be a problem of the old age, but sometimes even the young individual also get demented. So is there any age we talk about when the dementia starts? Anyone from the panelists? Dr. Desai?
Yeah, I thought maybe Suvarna might be a little more enthusiastic about taking this, but never mind. I don't think we have to look at dementia as an age-related problem. I mean, if you look at it philosophically, then the risk of having dementia is greater with the passage of time. And this is due to multifarious biological reasons. You're also looking at one way of looking at dementia is the balance between some acquired process that is decreasing the ability of the brain to function and the innate cognitive reserve of that individual. And we all have different reserves. No two individuals can have the same cognitive reserve because we are educated differently. Some are multilingual, some are not. Some have numerous talents and indulge in them, and so on. Some have risk factors, systemic risk factors, which have altered their reserve. So if you look at it at this way, that you have someone who has a pathology that is making the brain at risk, they have a reserve which is different, which is protecting or trying to overcome the pathology that is working in the brain, then you can't really have an age of onset. Yes, it is more common in the sporadic dementias. If one looks at Alzheimer as an example, yes, in the sporadic Alzheimer's, the likelihood of manifestation is much greater in the later decades of life. After 65, I would like to think in the 70s. But if one is unfortunate that you have a rare, say, familial disorder, and Dr. Kushwaha spoke about it in part of her initial conversation, that if one has, say, a gene in the family like presenilin 1 or presenilin 2, which makes the brain vulnerable for dementia at a young age, yes, one can get dementia at a younger age too. But by and large, I would like to think that per se, it is a disorder of late life, not necessarily a disorder of middle life or youth. And would you agree, Suvarna? I think.
Absolutely. Yes.
Okay, so the young people can also get dementia.
Atanu or Suvarna, that it presents in late life, but maybe the process of, the degeneration might start 20, 30 years before.
Yes,
is that right?
Yes, sir, that is true.
Yeah, that is true. That is really true. And that's been, again, our knowledge of the biology process being anteceding clinical manifestation by more than a decade has actually come from biological studies in genetically vulnerable families, because we have a CSF biomarker. So the studies were done in presenilin patients who were asymptomatic but had carried the gene, and they were serially studied in their cerebrospinal fluid biomarkers like amyloid oligomers and phosphorylated tau in the CSF. So yes, the process is long, and in fact, I think it's heartening to know that the process is long, which means that if this whole August audience discussed all the lifestyle mores for prevention, if we were to promulgate them in our lives, in our middle lives, then we can have the dream that Dr. Suvarna spoke about, no Alzheimer. So if we want no Alzheimer, I mean, we can't choose our genes, but we can definitely choose the way we live. So we ought to think we need to exercise, we need to eat judiciously what we consume. We need to make sure that if we have a systemic ailment like hypertension, diabetes, hypothyroidism, with a vitamin deficiencies, we correct that. And with the knowledge of the glymphatic system, we now know that when we sleep at night, we have a maid that cleans the brain at night. And this was discovered about 9 years ago. And then for 9 years of research, we've asked the question that this nighttime maid that is cleaning the brain, what does she clean? And it now appears that she cleans all the bad stuff that the brain doesn't want. It cleans it of amyloid, it cleans it of synuclein, and it cleans it of tau. All the bad stuff, which if it accumulates in strategic brain parts in a large number, can make the brain vulnerable. So we have to treasure and make sure that our restorative sleep, which is our only medication, which is not in a bottle and which has been given to us by nature, we cannot allow it to dissipate by late nights, by being indulgent with Netflix and other modes of entertainment. There is a common terminology now called revenge Netflix watching for being left out. So people are working hard all day and they want to not miss out on entertainment. So they are sleeping very, very late. And we know that sleep deprivation can have serious biological fallout. So I think the way to look at it is that if we know that dementia takes long, then this is the opportunity to grasp our lifestyle. We live a lifestyle which is positive, which is endowed with knowledge, and we promulgate in our life those measures that will make our brains less vulnerable.
Another thing which is, cleanses the brain is fasting. And you must practice intermittent fasting daily. If you fast for 15 hours, so, only fast, I think that will clean the brain. And
I'm very glad.
Autophagy, if you can fast with a longer, it will be much more better.
Yes, Chandrasekhar, that's very important because very surprisingly, there's a Chinese group that has looked at intermittent fasting and the polarization of aquaporin 4 of the glymphatics. This is published just about a few months ago. So there's a study from China that shows that if you do intermittent fasting, then the localization of aquaporin 4 on the astrocytes, which has to be polarized for the lymphatics to function well, is enhanced in intermittent fasting. So what you know from wisdom and from our cultural heritage is now being proven by science, and it's come back in a circle from China.
Yes, thank you very much. Suvarna, can you?
I am curious to know what Professor Arjun Das wants to say. He's raised his finger. I think that will be more valuable. Sir.
I think the most valuable thing that we can do in modern medicine, find a firm marker. See, you tell a diabetic man, you got diabetes, you got peripheral neuropathy, you got stroke. So unless you show him the figure and the disease matching, nobody will accept the restrictions or whatever you want to do. We should bend our effort to get a marker, simple marker, not a CSF marker. Nobody wants to go through that. So I think we should all try to show this is your marker. Do you want to go all the way there or you want to change? Then of course we should have methods of changing. There are many methods, at least I can think of many methods. We can slow down the process. I do it in my clinic, but leave alone the Alzheimer. You talk of dementia. So many diseases to do dementia. We can improve those educated people. I'll tell them to do crossword puzzles in the morning and night with somebody who's more educated than you. So we can think of anything, but unless you show a premature marker to that person to put the threat of life in him, because he must have seen what it means. Is there a marker which is easily available? I saw one blood marker has come. There was a paper recently. CSF has been there before. The blood marker is easier to use in public.
Yes, sir. It is not yet available, but probably it will come in the next 1 or 2 years.
Is there a paper now in the market that there is a blood marker? I thought I read it.
Yes, sir.
Finding neurofilaments in the in the blood.
Yes.
Somebody has worked it out.
Yes, sir.
And it would be very interesting to know from some time later from Professor Arjun Das.
I will find out. I copied the paper. I copied the paper
the
on
secret
the
of
computer.
good health.
I'll send it to you. Send it to you. I have made a copy and kept it. That's wonderful, isn't it? Just like you say, you got diabetic neuritis, this is your blood sugar. What can be better than that?
Sir.
Thank you so much, all of you.
Thank you, sir. So, some more questions in the chat box that if we can go. Mr. Manish Narnaware has written that can dementia be diagnosed by speech attributes, and also he has written some other questions as well, using the artificial intelligence for diagnosing dementia very early. So can I ask anyone?
It's a very, very interesting question.
Yes.
And I'm sure Suvarna will bear me out on this. There is a study that's been done that language decline in the construct of a language in a person who uses language daily, say for example a writer, linguistic decline can be noted very early as a marker of cognitive impairment. And as for example, there is a study that had looked at Agatha Christie's first book and the last book that she wrote. And very clearly, there was a huge difference in the construction of her sentences, the usage of verbs and adjectives, and the flow of her grammar in her first book to the last book. And Agatha Christie in her later years did have Alzheimer's disease. And they compared that with another elderly writer who did not have Alzheimer, P.D. James, who wrote criminal novels. And in that study, P.D. James' novels, the first one and the last one that she wrote at the time of the publication, which was about 5 years ago, had not changed. So there is this interest amongst researchers that could language anomalies in a learned person or in a person, even if not necessarily learned, who knows languages. In that language, is there a way of assessing this? And one of the research groups from Harvard actually met me about a year ago when they were doing a project with students who had developed a software to analyze 5 minutes of the spontaneous speech of patients and 5 minutes of a written text that they had to read out to the software. And what they were trying to do, and I believe the study is still ongoing, is to, through artificial intelligence, identify inflections in the way the text was read and in the way a narrative was made in spontaneous speech to try and identify whether there could be a basis for early cognitive dysfunction. So on a perceptual plane, people are looking at it, but at this juncture, we don't have anything concrete that can actually tell us. And I'm hoping Varna can add something to this.
We are not worked enough on FMR. FMR is the one that comes on before a person does anything. They just a little write-up on FMR, the activity before it's done. I think they should have standard FMR, then learn on, put it on all the patients, all kinds of patients. Maybe you'll find a pattern that will click.
Suvarna, I'm sure you have thoughts on this. Varna, tell us
Anybody
what you
working
think
on
about
FMR?
language.
That there are studies, basically, when you have two people who perform equally well on a cognitive test or a cognitive task, but if one person is recruiting more networks on fMRI or different networks on fMRI, that person is likely to develop progressive cognitive decline because they're already using strategies. So you're absolutely right, sir. Brain networks are one of the first to change in the face of disease pathology. And regarding language decline, there artificial intelligence is coming in to as an easier way of diagnosing natural language processing. So just record a short speech, and then you have different characteristics, phonology, semantics, prosody, phrase length, phrase utterances. So a lot of very good work is coming up on using technology and artificial intelligence in natural language processing to make a diagnosis of, to detect early changes.
Very good. Thank you for answering this question very beautifully. Now, there are some questions related to the treatment and the modern treatment strategies, like the role of monoclonal antibodies against amyloid, specifically for young onset AD. So anybody wants to answer this question, because this is an hope for those Alzheimer's disease patients, and probably the young people will always want to know what the breakthrough that is happening for the Alzheimer's disease.
Shall I take that?
Yes, yes, please.
So for the first time, the US FDA, which is the gatekeeper of all medication in the world, has approved a drug that will kind of clear amyloid from the brain. So that's aducanumab. So this is a breakthrough that the FDA has actually approved a drug for treatment. So if you're in America, you can actually get a drug that will reduce your amyloid in the brain. But however, this is under fair amount of controversy because it is felt that the approval was given prematurely. The endpoints were that the brain biomarkers improved, but the clinical improvement was not all that much. And there's mixed results from different studies. Having said that, the hope is that this will trigger more studies that will this is, and there are also lots of side effects. So it's called area. So there's inflammation and there are hemorrhages if you use this drug. So the fairly high incidence of adverse effects. But the hope is that this drug will be further improved so that the side effect profile comes down and it gets more specific against amyloid. So yes, in the few decades to come, the hope is that we will have better amyloid, anti-amyloid strategies, anti-tau strategies. And then we need to look at which genetic problem is there in familial dementias. So therapies against that particular gene are being developed. So people are creating cohorts of people who have, say, one particular kind of gene called a MAPT mutation or some progranulin mutation. So treatments that address the mechanisms are indeed the future. So I think there is some hope. But they're very expensive. The problem is we have, as a group of clinicians or scientists, we're very medical. We haven't done enough for carers. We haven't done enough for cognitive interventions. So that is backfiring very badly because while there is the scientific breakthrough, we have just spent no time on the psychosocial side of care, improving care systems, making dementia-friendly communities. So it's come as a backlash against the drug now.
Yes, thank you very much for highlighting this. But there is a ray of hope for the dementia sufferer. Maybe in the next decade, we will have more and more drugs at our hand to treat them very early. And as Professor Dr. Arjundas was talking about, we'll probably have a simple test, blood test for early diagnosis, and so that we can help the patients who are having the disease. Now, there is another question, very common question, is there any correlation between dementia and depression? And this is a common question often asked even in our medical seminars. So can anyone want to talk about Dr. Suman?
Yeah, this is very commonly asked, and this is very commonly correlated. Yes, we do have studies in which we have the patients who had been demented in their lifespan for a longer time, say if their dementia started since 30 years of the age. These patients tends to have dementia at the early age, right? So there is a correlation between dementia and depression, and some patients of dementia usually present with depression to start with. They go to the psychiatrist, they go to the psychiatrist for years together, say for 4 or 5 years, and getting treated for their dementia, getting treated for their depression. And one fine day, there is an initiation of the cognitive decline, and when they are found to be having dementia. So depression is a way correlated to dementia in this way.
Is there any? I think that. So thank you very much for giving us then what is the relationship between the dementia and depression. Depression can be a symptom, early symptom of dementia also. So
Yeah, sure.
like this has already been discussed. Very in a elderly person, first time getting depressed, one should look into that he or she might be having dementia. So there are many more questions, but most of them has been answered. Something Dr. Mesram would like to tell about what is the role of vitamin B12 and how periodically we should test vitamin B12 in an individual, particularly those who are non-vegetarian or vegans.
Yeah, I think we can measure vitamin B12. Sometimes the patient is not taking oral vitamin B12 or taking vitamin B12. It can be, you can test it by, homocysteine, which is a marker of B12 deficiency. If the homocysteine is raised, then you can assume that the person has B12. And you should also find out that whether the patient is on certain drugs. Like patient regularly take drugs for acidity. And these impair with the absorption of vitamin B12, and the persons can lead to vitamin B12 deficiency. So therefore, if somebody has a vitamin B12 deficiency, and sometimes you may get a result which is in normal range, but then that still can be deficient. So if here you should demonstrate or don't demonstrate, suspect that elderly person would have may have Alzheimer's, but vitamin B12 deficiency can contribute to some of the symptoms. So treat empirically with vitamin B12. And that is the idea, and I think a message I want to give, that any patient of dementia, you don't lose anything by empirically treating vitamin B12 deficiency, even if the levels are normal. And then you must, another drug that which is important, that Dr. Suman has mentioned about various drugs, but statins are the one drug which can cause dementia or manifest as dementia, which is very routinely used. And therefore, all these years, the cardiologist, by saying the heart healthy diet and use of statin, not only they spoil the hearts of the people, but they have spoiled the brains of the people all over the world. With very due credit to the cardiologist, that the whole cycle of heart healthy diet is totally wrong. And it is all the way reverse that, what has been, preaching for last 40, 45, 60 years. And we realize that it's a very wrong decision to put the heart healthy diet of high cholesterol, low fat diet. That is not, it has increased the heart attacks, it has increased obesity, it has increased so many bad things, and it has caused the problems with the brain.
Okay, thank you very much, sir. One related question to your diet and cognition. It was mentioned in this, somebody has written, it was mentioned in the discussion that omega-6 rich cooking oils should be avoided. Can you please give a list of omega-3 rich oils recommended? What about mustard oil, corn oil, etc.? So which oil is better and which oil is bad for brain?
I think I mentioned in the initial talk that the coconut oil is best. Extra virgin olive oil is good. Anything refined oil is bad. So don't use refined oil. If you want to use oil or groundnut oil, you used unrefined cold pressed oil. Then your ghee is very good. The butter is very good. So these oils are very good. And even flaxseed oil is very good. You may not like the taste, but the flaxseed oil has got good number of omega-3 fatty acids. So I think we have to keep changing, and the oils that you use, never use refined vegetable oils.
Yes. Thank you very much, sir. There is another question, very interesting. Are there any mind exercises which youngsters can practice on day-to-day basis as precautionary measures for dementia? Dr. Joy?
Yeah, that's a very provocative question. My own philosophical takeaway from understanding and trying to understand what this whole biology of cognition and cognition at risk is in these last 25 years and perhaps the other years to follow in neurology is that the simplest takeaway one can take is that you've got to have a constant usage of brain. We are not even using 5 or maybe 10% of our cerebral capabilities, most of us. And we all think that people have limited talents, but the brain is actually unlimited in the talents that it can exhibit if it is given an opportunity to do so, if it's given the desire to do so. We always thought that handedness was related to language, left side, language dominant, right side, artistic talents. Not true. There's new studies which clearly show that it's bihemispheric. All our networks are functioning bihemispherically. So the more you use the brain in goal-directed behavior, the better it is likely to be. My conviction is that one of the tragedies of retiring elderly people at 58 and 60 is that we are taking away, in many of them, goal-directed behavior. And even if people are not working, if you look at ladies who are in housewives and homemakers, when they grow older, sometimes the daughter-in-law steps into her shoes and takes over the entire goal-directed behavior in the household and kitchen, especially if she's an aggressive person. And suddenly, the individual is bereft of goals and goal-directed, motivated behavior to be executed. And that is really tragic. We need people to find new things to do, even do the old things. And when we do things with interest and we do things with passion, sometimes it is somewhere protective in brain functioning. There are some thoughts about cingulate gyrus, and I don't want to get into it just now. But rather than have very empty advice like doing Sudoku or doing word puzzles, I think it's important to do activities that you enjoy doing. It may not necessarily be puzzles. It may not be Sudoku. It may not be Scrabble. It could be simple things like painting. It could be indulging in music. It could be doing bonsai in your garden based on whatever you enjoy doing. But we need people to do things with love and goal-directed behavior. I think that is cerebrally preserving. And I can see Suvarna smiling there, so maybe she can chip in here and tell us what else we could tell the audience.
No, I agree. Although I wouldn't tell like very young person what to do to prevent dementia. I mean, maybe sometime in later midlife, but young people do something to prevent dementia. I think I'd rather ask them to do something more productive. And I think that will anyway reduce the risk of dementia.
Yeah.
Yes. So I think we have covered all aspects for the disease, and the other questions are related to some of the topics we have already discussed about the prevention, about the risk factors, modifiable and other non-modifiable risk factor, and everything. So probably it was a great session for all of us, and we have covered all aspects of dementia, including Alzheimer's disease and other form of dementias, their causation, their risk factors, their preventive measures, manifestations, and also the treatment strategies, caregiving details. I take this opportunity to thank all the panelists, particularly Dr. Desai, Dr. Suman, Dr. Suvarna, Ms. Sally, and Dr. Dave, and also Dr. Mesram, who participated in our panel discussion, and also probably because of his enthusiasm, this program was made it possible. And I sincerely thank Professor J.N.K. Murthy sir, the President of Indian Academy of Neurology, for conducting such a beautiful program. And of course, it is no word can be that to our beloved Dr. Arjun Das sir. He is so active at this age, and he participated actively in our this program. Thank you very much, sir. And I now, yes.
No, we want to thank you. I have not seen such a patient, superb moderating of a session. I think the credit goes to you for taking us through every point, listening to us, and making us connect with the audience. Thank you, Atanu.
Thank you very much, sir. Dr. Misram, sir, could you tell something?
Yeah, thank you very much. I think, Atanu, it was a wonderful session, and I would like to thank Professor Jordandas, not only inaugurating, he was not well. When I called him in the afternoon, he was not well, and I said, you just give the inaugural address and you can log out. But then he stayed the whole time with us, and thank you very much, sir. And would like to thank Professor Murthy and all the panelists and Atanu. I think we had a very, very wonderful session, and this dementia is a burning problem. It's a very interesting problem, and I'd like to thank all the people who have joined on Zoom.
Chandrasekhar, I would also thank.
Yes,
I would like to say something.
Yes, sir, please.
No, it's an excellent session, and everybody talked in a simple language so that the common people can understand what is dementia and how can it be prevented. The emphasis more on prevention is a very healthy aspect of this panel discussion. Thank you very much on behalf of Indian Academy of Neurology.
Thank you. Thank you all.
Thank you.
Would like to...
Sincere thanks to Professor Arjun Das.
yes.
Thanks.
Thank you, sir.
And we had, participation from all across the countries, different regions, and
Yes.
audience.
Thank you, sir. So thank you all
Thank you very
for
much. I think
involving
we
me
had a very
also.
wonderful session.
Thank you.
Thank you.
Thank you.
Okay, thank you.
Thank you. Thank you, sir. Thank you, Mansi.